We're going to go ahead and move on to the feature lecture number 3. My results are better, returning athletes and with hip labral tears, and that's going to be given by Dr. Marc Philippon out of Vail, Colorado.
All right, so I don't know if our results are better, but I'll just give you our approach to returning athletes with hip labral tears. We'll start with our disclosure. We receive royalties from Smith & Nephew, Bledsoe, Donjoy, and our institute receive funds from these companies as well as private benefiters. So hip injuries in the athlete are getting more common, especially in athletes who have involvement in contact sport and also rotational maneuvers. You can see here it's a plant, it's a knee in a hyperflexion, and these kind of injury are not that uncommon. And now that we have better ways of diagnosing the problem, and most importantly we have ways of treating this, we're getting more information, and now we're starting to have our outcomes being published. This is Dr. Bird just mentioned that don't delay the treatment. If we have a symptomatic individual, I think one of the first keys to make sure we have an appropriate diagnosis and an early intervention. It's important to also look at the extraarticular soft tissue pathology, because often you will have concomitant soft tissue problems such as adductor inflammation, lower rectus inflammation, and I think it's very important to consider both in sync. So often what we'll see is this kind of problem. You'll see the intra-articular problem, but also a lot of these patients will present with pubic cleft pathology as well, lower rectus, abdominis problem, external oblique, internal oblique problem, adductor problem, and if you go more lateral, you can start with the gluteus medius pathology, trochanteric problems. So I think, and obviously the hamstrings are a big part of the issue as well. So I think hip pain could be divided in intra-articular, but also, very importantly, we have to consider the extra-articular problem, which is a result of the intra-articular pathology. So our approach is, when we have a patient presenting with groin pain, we try to divide them into extra-articular and intra-articular groups. The extra-articular group, we always want to know if it's a chronic problem or an acute problem, because it makes a difference in the type of intervention that we're going to do. And then our treatment algorithm for those patients is, we used to use more steroid injections combined with physical therapy, but now our algorithm has evolved more to platelet-rich plasma therapy, and we've had very good success with that therapy for that type of problem. As far as intra-articular problem, if we have a documented labral tear, documented condyle problem, we'll try 6 weeks of conservative therapy. If it fails, then we'll consider surgeries. This is a busy slide, but I think for the labral pathology, to sum it up, we try to preserve the labrum in most instances. We try if we have enough substance. If not, now we have evolved into considering labral reconstruction, because we feel that it's important, especially in these elite athletes, to preserve the suction seal and the role of the labrum. And my first 10 labral reconstruction were all professional athletes. Labral classification, I think it's important to understand what kind of labrum tear that we're treating. We can divide that into the morphological alteration associated with impingement, cam and pincer. Most of the pathology we see will be a mixed type. We also have to consider the bony morphology, such as dysplasia, because if you have under coverage, you have to be very careful as far as resecting the labrum or even addressing a dysplastic patient with the arthroscopic approach. Functional alteration, we divide that more into instability. Now we see more and more patients, especially in the female group, in the female athlete with psoas impingement. Traumatic, a little bit of the video I showed you earlier, you have to be very careful as far as considering dislocation or subluxation, especially subluxation. Dr. Warren and Dr. Mormon wrote a paper on a patient with traumatic dislocation, subluxation, and definitely subluxation is a very important pathology that we have to consider when we see a patient with a traumatic injury to the hip. Degeneration, hip degenerative disease is also part of the labrum spectrum. Those are more mucinous degenerated. There's yellowish discoloration, and those sometimes are difficult to repair. This is an example. Before we start addressing the conflict, we will look at our conflict from the peripheral compartment. So this is a bruised labrum. I can see the convexity of the head and neck causing the problem. Probing is very important. So we have an anterior superior labrum with a separation here and a wave sign, a lot of maceration of the tissue, and this is what is important to identify, is the amount of chondral flap, the amount of delamination, and the amount of instability of that cartilage structure, because by doing your pincer resection and your trimming and your refixation, you'll be able most of the time to address that pathology. So what's the rationale for labral repair? We looked at our a cohort or revision patient when I moved to Vail, and we look at the main reason for revision, and what we found is a lot of the revision or failure were due to impingement that was not initially addressed, or impingement that was inadequately addressed. But also residual labral pathology was an important factor. This is an example how there's a small separation here, but it's important if you decide to address an anterior superior labral tear and you have a separation that you address the whole separation. So sometimes the whole pathology. So to address the whole pathology, you often have to separate the labrum from the small separation and then address the pincer from behind with the motorized burr to make sure that you remove the overhang that's causing the pathology. This is the placement of the anchor. I think it's important to place your anchor as close as you can to the acetabular rim, the cartilage surface. This is important because you don't want to have an everted labrum or an inverted labrum, and I think in the hip you have to be careful on the acetabulum. It's not like the glenoid. The glenoid is flat, it's easier to place your anchor. Here you have to avoid penetrating the articular surface, but you also have to be as close as possible to the articular surface. Actually, if you can play that video. So again, the anchor is being placed, and we introduce the suture between the interval of the labrum and the bone, and then it's important to tension your labrum, your suture adequately so your labrum sits where it's supposed to. Again, here we're going through with a arthropierce, and we place our suture on the capsular side, and this system is designed to allow for recession of the knot. And then we always verify the seal after the repair to make sure that it's not everted or inverted and there's no residual impingement. Play the video, please. Here, this is a right hip. We're coming from the side portal, and I just want to show you this to show the importance of tensioning appropriately, but also the importance of, next one, the importance of the suture management, so there's no interference from the suture and the adjacent soft tissue. Here it's a right hip going a little more anterior, placing the suture in the interval, penetrating. You have to be careful when you penetrate here to avoid damaging the labrum. So you have, if it's too macerated, we'll loop the suture. And then this is the locking stitch to make sure that the suture stays on the capsular side. This is to show you on distraction. We want to verify that it's as anatomic as we possibly can make it, and then this is after the convexity of the femoral head opposed the labrum and confirm the seal. So again, you have to address the underlying condition associated with the repair, and if you this is an example of a cam impingement where the convexity of the head certainly is the cause of the problem. So you can see how by rotation and flexion, if you have an abnormal head and neck morphology here, you'll have a premature engagement of the convexity at the chondrolabral junction, causing a separation of the labrum from the rim. And understanding that is very important because that allows you to be better prepared at the time of surgery to address the pathology. So this is where most of the, in a cam situation, most of the problem occurs between the cartilage and the labrum. Separation is already present. So knowing this, you know that when you go in, you're going to have to address that. As far as the pincer, the next slide, the pincer, you have similar situation. The labrum is also damaged. However, the conflict is different here. The conflict is the neck abutting the overcoverage, and it's more of a squeezing effect of the labrum being squeezed, and then what you're seeing in that situation is more a stable rim chondrosis, and then you have a contractile lesion because of the levering effect anteriorly in the posterior inferior portion of the acetabulum, and you'll see that as the head comes out here. So what you're addressing here is a little different. Your labral treatment will be different, but when you consider treating the person with this labral pathology, if it's a mixed type, which is most of the time, you have to take that into consideration for your rim treatment, and this is what you're seeing at the time of surgery. Rim trimming, we use a 5-5 burr. This allows you to stabilize the chondral surface at the same time as you're removing the bone. So and often in the corners we'll use an osteotome, and that's another tip because it's very hard to get there with the burr. The dynamic exam is very important, and I think I'll leave you with that statement is the dynamic exam will verify your labral stability, will verify the resolution of the conflict, and I think most importantly, I think this is an example of a psoas impingement release. Most importantly, what we do in our situation, we close the capsule, especially patient involved with rotation sports. Our experience has been positive. I think peer review and the rehab is also an important part of the process. We do a sports test, we do early motion, and most importantly, I think, is that we have to have published outcomes, and if we follow a good technique, if we follow the algorithm we use in our published outcome, we've been happy with our results, and I think, again, it's to pick the right patient, address the full pathology, and have good rehabilitation. Thank you very much.